Today we're tackling a topic that's really widespread but, well, not often discussed openly, dyspareunia.
That's the medical term, yeah, for recurrent pain during sexual activity.
And the numbers are pretty staggering. Our sources show a lifetime prevalence hitting nearly 18%.
Almost 1 in 5 people. That's huge.
It really is.
So our mission today really is to cut through the silence. We want to quickly distill the facts, the different types of pain, the causes, what the evidence says about treatment.
Because it is treatable, right? That's the key takeaway.
Absolutely. It's often complex, lots of factors involved, but definitely treatable. That's the most important message.
Okay, so let's unpack that complexity. You said multifactorial. What does that really mean here?
Well, it means it's rarely just one single thing. It's usually this interplay between physical issues, maybe hormonal changes, and psychological factors too.
Like anxiety. I read that anxiety, or even just the fear of pain, can cause muscles to tighten up automatically.
Exactly. That's a perfect example of the mind-body connection here. Fear leads to muscle guarding, which then becomes a physical source of pain. It's a vicious cycle sometimes.
And does it matter where the pain is felt?
Oh, definitely. That's actually a key part of figuring things out. We talk about superficial pain that's right at the vaginal entrance, often related to skin issues, maybe past injuries or lubrication problems.
Okay.
Then there's deep dyspareunia that's felt, deeper inside the pelvis during intercourse, and that often points towards issues with internal organs or conditions like, say, endometriosis.
Right. So drilling down into specific physical causes, what stands out in the research?
Well, two big areas. First, infections. Things like STIs, they can cause inflammation and pain, and obviously need specific diagnosis and treatment. You have to rule those out.
Makes sense. Standard procedure. What's the second area?
The impact of pregnancy and childbirth, postpartum perineal injuries, significantly raise the risk.
Okay, that seems logical. Injury equals pain.
Yes, but what's really interesting and maybe less obvious is that how the perineal repair is done right after birth can actually affect the likelihood of pain developing later on, sometimes years later.
Wow. So the technique matters that much.
It seems to. It really highlights how important those initial interventions can be in preventing chronic issues down the line.
Okay, this is where I think it gets really interesting for people listening. What actually works? What does the evidence say about effective treatments?
Yeah, and the good news is there's strong clinical evidence for certain approaches. Systematic reviews really point towards physiotherapy.
Physiotherapy, like for pelvic floor muscles.
Exactly. Pelvic floor training specifically comes up again and again as a core first-line treatment. Also things like electrotherapy in some cases.
How does physio help with pain during sex?
Well, for many people, the chronic pain leads to the muscles down there becoming constantly hypertonic, is the term. So pelvic floor physio often isn't about strengthening, like doing Kegels. It's actually about learning to relax and release that tension, down training the muscles.
Ah, okay. So you're treating that muscle guarding we talked about earlier.
Precisely. You're breaking that cycle. And electrotherapy, which sounds a bit scary, but is usually just mild stimulation, can help kind of recalibrate the nerve signals, quiet down that persistent pain message.
That makes perfect sense. But I've also seen sources talk a lot about hormonal therapy, like localized estrogen, especially being recommended first. Is that a conflict?
Not really a conflict, more like different tools for different root causes. Physiotherapy is brilliant for the musculoskeletal side, the muscle tightness.
Right.
But if the underlying issue is clearly hormone, maybe vaginal atrophy after menopause or due to certain medications, then hormonal therapy is essential. It addresses that specific problem.
So it depends on the diagnosis.
Totally. That's why a thorough workup is so important. You need a good history, a physical exam, and crucially, that pelvic floor assessment to figure out what's driving the pain for that individual.
So the main message for you listening is, don't ignore this. Seeking care is really crucial.
Yeah. Absolutely. The impact isn't just physical. We see significant effects on mental health, on relationships, on self-esteem. It's not something you just have to put up with.
Definitely not.
But, and this leads to a kind of provocative thought, while we have good treatments when we can pinpoint a cause like infection or muscle issues, the path forward isn't quite as clear for what we call non-specific or idiopathic dyspareunia. That's basically pain, where we can't easily find a direct physical cause with our current methods.
So pain without a clear why.
Exactly. And for those cases, the research still needs to figure out the absolute best diagnostic tools and treatment combinations. Some physio techniques, for example, still lack really standardized protocols. So the question becomes, How do we bridge that knowledge gap for people whose pain doesn't fit neatly into the boxes we currently understand?
Hmm. That's definitely something to think about. Where does the research go next?
That's the big question. Finding answers for those complex idiopathic cases is really the next frontier.